So this is not one case, it's actually five, but I'm going to present them in a condensed format. And I'm hoping Rob and Jod are able to stay on. I thought of this because of there was a case presented last time, and one of the surgeons said that we don't need to do the 24-hour urine and hyperpara anymore. And I felt like that was wrong, and I just want to present. And these are all cases I've seen in the past couple of years. So this first one's a 64-year-old woman with hypercalcemia for a long time. She has uric acid stones. She also has a patient and sister who are hypercalcemic, and they've had testing of the calcium sensing receptor, which was negative. Again, the patient and sister have had the testing negative. Her mom is also hypercalcemic. Calcium 10.5 to 11.3, phosphorus a little low, PTH high normal to a little elevated, magnesium slightly low, 25D normal. Urinary calcium, and I want to point out this is 208, not that low, but if you actually do the calcium to creatinine clearance ratio, it is quite low. The next one is a 50-year-old man, hypercalcemia noted about a decade earlier. He was referred by an endocrinologist, and the referring endocrinologist had done a calcium sensing receptor test, which was negative mutational analysis at Mayo Clinic. Family history was negative. Calcium levels were between the high 9s and mid 10s. When I saw him, an ionized calcium was elevated, a phosphorus low normal. Again, one PTH elevated, one PTH inappropriately normal, magnesium normal, vitamin D normal. Again, urine calcium greater than 100 on 2 occasions, but if you do the calculation, it's low. The next patient is 68 years old. She had, in the late 80s, a 3.5 gland parathyroidectomy. I've requested those records, but have not got them. But since I saw her, her brother and mom were found to have hypercalcemia. Calcium's 10 to 11, phosphorus 2.8, PTH levels high normal to elevated, mag normal, vitamin D normal, and urinary calcium in her low with a low calcium to creatinine clearance ratio. The next patient is 36 and she's now pregnant, or when I saw her was pregnant. At age 32 though, she was diagnosed with primary hyperpara, had a urinary calcium of 239, and had genetic testing at that time, which was MEN1 calcium sensing receptor and HRPT2 testing. They did that just because of her age. A single enlarged gland was removed, her intraoperative PTH decreased, but the hypercalcemia persisted. Her family history is reportedly negative. Calcium's 10.8 to 11.1 with normal to low normal phosphorus. PTH is inappropriately normal. Vitamin D slightly low. And again, she's had urine calciums now twice, both more than 200. But if you calculate the calcium to creatinine clearance ratio, it's borderline to low. And the last one is a 56-year-old woman with hypercalcemia and markedly low urinary calcium. The referring endocrinologist, she had no mutations in calcium sensing receptor, CDC73, MEN1, RET, and the MEN4 gene. Her son might have hypercalcemia, but I don't have anything on this kid yet. Her calcium levels are substantial, 12.6 to 13, with normal phosphate levels, significantly elevated, or low normal phosphate, significantly elevated PTH, mag normal, vitamin D normal, urinary calcium very low, and calcium to creatinine clearance ratio very low. Now, this is the genetic testing. And interestingly, on this guy, when I probed a little more, I found that his 15-year-old daughter has hypercalcemia. And this is something I've seen a couple times when you ask people family history, they only look backwards and not towards their children. But patient 1 has a variant of unknown significance of GNA11, that's FHH2. I think based on the family history, this is a new significant variant. She tells me that they've tested it in her unaffected and affected sister, and it correlated with disease, but I have not gotten that yet. Patient number 2, now this guy had negative calcium sensing receptor at Mayo, But what they found was a large deletion at in vitae. And I think that may not have been picked up because if they only look for point mutations in some assays. Patient 3 has calcium sensing receptor. Again, she's already been operated on, and she has, I'm sorry, this thing keeps popping up, FHH1. Patient 4, the woman with pregnancy who's had one surgery, has FHH3, AP2S1. And the last patient also has FHH3, the woman with pretty markedly elevated calcium levels. So just to remember, FHH, there are 3 genes now associated with it. FHH3, they may have more severe hypercalcemia and PTH elevation, and they may respond to cinacalcet. Clues: onset at younger age, lifelong hypercalcemia, family history, but I'd be careful about verbal only. I like to see the results. They're more likely to have a normal PTH as opposed to an elevated, and they may have a higher magnesium, but I don't find that useful as a discriminator. So, you know, in my practice, if I have a low urinary calcium and calcium to creatinine clearance ratio, you know, obviously think about FHH. You want to think about if they're on a thiazide diuretic or indapamide or even spironolactone. CKD will lower it, lithium, incomplete collection, vitamin D deficiency or low calcium intake, race, African Americans have lower urine calcium, and lab error. If family members are known to be eucalcemic and the hypercalcemia is clearly acquired, it's probably primary hyperpara. But I say clearly acquired because some people say, well, they've only had calcium levels for the past 10 years, and I see one of 9.9. Even FHH patients can bounce between the high normal and elevated range. So here's a study where they looked at FHH1, 54 patients, and compared them to 97 primary hyperpara patients. And they found that using the calcium to creatinine clearance ratio of 0.01, which we used to use, missed 20% of the FHH. If you use 0.02, you got most of them. And the problem, of course, is there's a huge amount of overlap. But in my practice, at least, I don't want to operate on FHH, and I think sensitivity is most important. So these are the guidelines from 2014. I don't know if the new guidelines will be any different on who should have genetic testing, but we'll find out soon. So the calcium to creatinine clearance ratio, if it's less than 0.01 in a patient with an adequate vitamin D and a GFR greater than 60, that's almost certainly FHH, and consider genetic testing to confirm and facilitate. If it's in this borderline range with a 25D that's adequate and normal renal function, they suggest doing genetic testing. And in my opinion, you need to look at the old calcium levels and family to the extent you can. And when you do testing, we do all 3 genes. So I'm going to quote Rob Wormers. Rob Wormers told me this. This is his quote. He said, FHH is out there. And I'm going to say in my practice, it's out there. And I think it's I probably missed it over the years. I don't say that proudly, but I probably have. And in my opinion, the 24-hour urine calcium creatinine remains an important part of the primary hyperpara evaluation and should not usually be omitted. And I'll ask Rob and Jod if they want to comment on that.
Well, since you quoted me, I agree. In all reality, though, we see FHH, there's no doubt about it. We see a lot of recurrent or persistent disease, and you know, when we see those patients, we certainly get a higher prevalence of FHH. So it's out there. I do the 24-hour urine calciums almost always. I mean, if they had a 9.2, 9.3, and it was solidly in the expected range, and then they're postmenopausal and it's high, there you would probably, it's not as important unless you want to use it, because the new criteria for, they have been published, Joe, the new criteria, the new
Right.
And they're basically lowering the 24-hour urine threshold for operating now. In women, it's greater than 250, and men greater than 300. So now it becomes even a lower threshold to operate, you know. So, but yeah, I agree. It's out there. I'm sure I've operated on them. I've never actually diagnosed FHH3. So It's pretty amazing, the series of cases you just showed us.
So yeah, I mean, I just think it's part of the evaluation. I think most of the time, if you skip steps, you'll be fine. But I think part of what makes us do things right is kind of saying, I'm not going to skip steps unless it's really obvious. And I agree with Rob. If it was 9.2, 9.2, 9.3, and then you notice over the years it's 9.5, 9.8, 10.3, and settles around 10.5, yeah, that's clearly acquired. But some of these people, you know, they had one normal calcium, and then you see, you know, a bunch in the low 10s, and the normal one's 9.9. It's not so obvious. And,
Yeah,
go ahead.
If you look at the prevalence data in individuals under 50 of FHH versus, you know, primary hyperpara, it's not that far, it's not that different. It's after menopause where you see a bigger increase. So there's some recent prevalence data of the UK, which is surprisingly high.
Really?
Yeah, I'll send you the reference.
Thanks, Rob.
It's really a lot more common than we think, based on FACR's data anyway.
Okay. You know, I trust that.
Hey, this is Jad. I also agree with what you said, and what you showed, Joe, is actually interesting because I also rely more on the 24-hour urine calcium rather than genetic testing, because you miss a lot when you do genetic testing. And clearly, with the one case you showed, you had to repeat it twice to find the variant. So negative testing doesn't mean much to me when I see these patients.
And I think the other thing is do the calculation. You know, just because the urine calcium is 200, if you don't do the calculation, you may get burned. I think a lot of people thought, well, if the urine calcium is above 100, it's not FHH in years past, not recently, but in years past. And I think I've probably missed some FHHs in those situations.
I've had an FHH with 24 urine calcium in the 300.
Really?
And you do the calculation, and it was actually less than 0.01. And
wow,
that was a persistent patient. So
there you go.
I think, you know, yeah, you can't rely on a single number. You gotta do the creatinine and do the fractional excretion. And John's right, 30% of FHH patients have no mutation identified. So.
Are we having any difficulty getting the genetic testing covered, or is it okay?
So I can tell you at MCW, so we do it all through our genetic counselors. So if I have a patient with familial hyperpara or suspected FHH or something like that, I send them to the genetic counselors, and they are much better at getting it covered, and it takes that hassle out of my hands.
Yeah.
And I for the most part, since it's in the guidelines, and I assume that part of the guidelines haven't changed, Rob, is that right? Genetic testing part?
They actually did change it, yeah. They're basically, yeah, there's some changes where they call out exactly who to screen. So less than 30 at the age of diagnosis.
Okay.
Family history, multi-gland disease, parathyroid carcinoma, atypical parathyroid adenomas. I think that's
okay. So I sent it to them, and I think they do. The Invitae has a 7-gene panel that they do, and it's much cheaper to do that than to do it sequentially, because I think the Invitae panel, you get 7 genes. If you did them sequentially, you'd break even at 2. And it's not, you know, it's just not worth it, and the time it takes.
In general, the key to insurance coverage is to emphasize that it alters the care of this particular patient. Most insurers are really looking for a difference between genetic testing to inform risk of family members. Actually, you should probably just not even say that, because that's a no-go. But if you say this result will determine whether this person has surgery or does not have surgery, I have never had it denied.
Yeah, I agree with that. I agree with that.
Hey,
Um,
Joe,
yeah.
this is Paul, a surgeon, so you're gonna have to help me out here. FHH, does that mean it's not gonna require treatment? And if,
What it means is if you operate, there's only two outcomes, in my opinion. And one, they kind of stay the same. If, you know, the calcium doesn't change much, it because it's a calcium sensing problem. Or if you take everything out, they end up with hypopara. So what it means is the patient shouldn't be subjected to unhelpful and unnecessary surgery.
okay, but how would you treat the hypercalcemia then?
Well, fortunately, most of them have mild or moderate hypercalcemia. And the patient I presented with the very high calcium levels, she really doesn't have any symptoms, but we tried cinacalcet based on a report in the literature, and she didn't tolerate it. And we retried it every other day, and we couldn't get her to take it. Any ideas from anyone on doing anything about her calcium other than keeping her hydrated?
That's what I would do. The only thing I've seen are links with pancreatitis with more with
Yes.
FHH. So, and there's a gene relationship with that, I understand too. So, but I'm not sure if you lower it with cinacalcet, if that helps.
Yeah, she didn't tolerate it anyway.
Joe, I don't know if you've tried cinacalcet at the 15 milligram dose. The pharmacist will tell you not to split it, but you can split it. And the 15 milligrams, especially for older folks, seems to be a little better tolerated than the 30.
Yeah, that's something we could try. That's a good idea. We have done that, actually. I don't know about her, but we've done it in other patients. But it's amazing. Dialysis patients tolerate it much better, but I think that's because they're sick already. They already have nausea and feel terrible. So
All right, any further
I think
questions?
we'll probably use time. Thanks, everybody.